everybody. Welcome to the RSNA Radiographics podcast. My name is Lily Wang. I'm a radiologist from University of Cincinnati. Today, we have a special guest, Dr. Asha Sarma, a pediatric neuroradiologist from Vanderbilt University Medical Center.
Hi, I'm Dr. Asha Sarma. Thank you for inviting me to the podcast.
Thank you for coming. So today's podcast focuses on an important and sometimes confusing topic. The article is titled Imaging of the Cerebral Veins in Pediatric Patients Beyond Dural Venous Sinus Thrombosis. This article is by Dr. Sarma and colleagues from Vanderbilt and Emory University. So to begin, Asha, can you tell us a brief overview of this article and its significance?
Absolutely. The article, Imaging the Cerebral Veins in Pediatric Patients, provides an in-depth exploration of imaging of the cerebral veins in children. And we decided to write this article because the entities we describe are less well known to a general audience, but are clinically important, and correct diagnosis can affect the patient management. Imaging of the venous diseases in children extend beyond dural venous sinus thrombosis and include a wide range of congenital and acquired disorders. It's very important to understand the venous anatomy, the optimal imaging techniques, and features of various pediatric venous diseases in order to make optimal radiological diagnoses. Our article aims to shed light on some less discussed disorders, including those involving the medullary veins, cortical veins, and the bridging veins.
So most radiologists probably struggle to recall the embryology we learned in medical school. What basic aspects of intracranial venous embryology should be understood by the radiologist?
Great question. The radiologist should know that unlike the arteries, intracranial venous development is a relatively passive process, and that explains the wide range of normal anatomic variation that you see across individuals. Venous development depends on multiple factors like oxygen concentrations, hemodynamics, and the development of the brain and skull, and largely occurs later than arterial development, for example, in the second and the third trimesters and even after birth. Disruptions to the venous development can result in developmental venous anomalies, Sturge-Weber syndrome, and vein of Galen malformations.
That's interesting. So what unique anatomic factors are important to understand for imaging pediatric venous diseases?
Good question. The normal anatomy of the deep cerebral veins and the dural venous sinuses is better understood than the anatomy of the medullary, cortical, and bridging veins. In short, the deep and superficial medullary veins traverse the white matter and feed into the pial veins superficially in the subependymal veins at the deep aspect. And the subependymal veins feed into the deep venous system, while the pial veins drain into the superficial cortical veins. The superficial cortical veins then feed into 8 to 12 larger dominant cortical veins that then feed into the dural venous sinuses. The bridging veins are short venous segments that cross the external arachnoid limiting membrane in the dura. They bridge between the superficial cortical veins and the dural venous sinuses, and we have some diagrams of this in our article. In children, they're prone to tearing and thrombosis with impulse loading forces like in high energy mechanisms such as abusive head trauma with shaking and high-speed motor vehicle collisions. And this might be because they're relatively fixed in the position relative to the moving tissues around them, which makes them prone to shearing. And when they're injured, this results in bleeding into the subdural space, which is a potential space. A few anatomic variants that may lead to confusion when imaging the intracranial veins include normal variant venous atresia or hypoplasia. So often one of the transverse sinuses is smaller than the other. Arachnoid granulations, and venous sinus cephaloceles.
Okay. So when we image veins in children, what are some techniques that we can use and what are used in different type of situations?
Good question. So we use multiple modalities in a complementary fashion. When we use ultrasound quite a bit, actually, as well as CT, MRI, and catheter angiography. For the way we use ultrasound, so portable head ultrasound may be useful to determine the patency of the dural venous sinuses in neonates. For example, when the dural venous sinuses have looked dense on a head CT, which is a really common scenario that we run into, it's really easy for the sonographer to place a probe on the transverse sinuses or the superior sagittal sinus to show that they're patent, as well as to determine the flow dynamics with Doppler, which we sometimes do in vein of Galen malformation.
So if I'm looking for dural venous sinus thrombosis, what is the best study to do?
So again, I think the different modalities are complementary. CT is often used in patients with suspected venous infarcts or thrombosis in the acute, for example, the emergency setting. And CTV is also a great troubleshooting modality when you see artifacts on MRI or MRI is not feasible or safe. And it can be used in patients who have a lot of motion artifact and things like that because it's so fast. Of course, we usually try to use radiation sparing modalities in children, but CT is a really important modality. But MRI, I would say, is the workhorse for most pediatric cerebral venous imaging. So in addition to the basic standard sequences we usually get, like T1, T2, FLAIR, and gradient echo sequences, post-contrast 3D gradient T1 weighted imaging, like a stealth or an MP-RAGE sequence, is a particularly useful sequence that we can also use to generate MPRs and volume rendered 3D reconstructions, which can be quite helpful. MIPS, maximum intensity projection, and multiplanar images are useful in all of the MRV techniques. And when available, weighted MIP images can improve the visualization of the superficial veins. The volume rendered reconstructions are pleasing to look at, but they can also improve superficial venous visualization by obscuring deeper vessels with residual background signal. And there are various MR venography techniques which we outlined in the article, including the pros and cons to the different pulse sequences. But in brief, and to summarize, the specific pulse sequence should be chosen based on which veins you're interested in. So you should think about the artifacts that you might encounter. For example, time of flight MRV may have artifacts from in-plane flow effects. So for example, you wouldn't want to use a coronal sequence to look at the bridging veins, while phase contrast MRV may have artifacts from slow or turbulent flow.
Those are great tips. So when we do MRVs in children, should we give intravenous contrast?
So contrast enhanced MRV is used in a lot of scenarios. It has the fastest acquisition time, but we should use contrast judiciously in children due to cerebral gadolinium deposition. MIPS, MPRs, and 3D volume rendered images are often useful reconstruction techniques. And those contrast enhanced 3D T1 gradient echo sequences can be really useful when making those kinds of reconstructions. And these sequences are also the most sensitive for non-occlusive thrombus, but non-contrast MRV techniques can be helpful to determine whether a thrombus is occlusive.
Oh, okay, that's great. Are there some newer and emerging venographic techniques?
Yeah, so there are a lot of things kind of coming down the pipeline that I think will be applied to pediatric cerebral venous imaging in the future. So dual energy CT, spectral CT in general, provides increased tissue contrast resolution of the image materials. For example, when you need to distinguish between iodinated contrast and calcification or something like that, and can enable differentiation between calcification, clot, and adjacent hemorrhage. Spectral or photon counting CT is another emerging technique that shows promise for improving vascular imaging and decreasing dose. Four-dimensional flow imaging is currently used mainly in cardiac MRI, but because this technique works well for imaging slow venous blood, it may be useful for evaluating idiopathic intracranial hypertension or venous thrombosis. And in terms of AI, synthetic MRI is a machine learning algorithm that can improve imaging in various ways, including noise reduction, improving spatial resolution, and correcting artifacts. And it's yielded impressive results in motion correction, mitigating the artifact that commonly degrades non-contrast MR venograms, especially in children. Synthetic angiographic images may also be directly generated from routine non-angiographic sequences, which can dramatically decrease the imaging acquisition time, which we value in pediatric patients.
Yeah, exactly. I mean, even some adults who can cooperate, that will be very helpful. So what are some congenital abnormalities or pathological conditions that can affect cerebral veins in pediatric patients?
Yeah, this article covers quite a range of congenital and acquired pathological conditions, and it can affect the cerebral veins in pediatric patients. These include dural sinus thrombosis, venous malformations, venous infarcts, arteriovenous malformations, and congenital anomalies. And in the article, we divide the congenital disorders into non-syndromic and syndromic disorders. The non-syndromic disorders that we cover are atretic cephaloceles, which are associated with cerebral venous anomalies like persistent falcine sinus, vein of Galen aneurysmal malformation, and venous anomalies that are seen in patients with malformations of cortical development. A few additional congenital disorders that we cover include varices, giant dural sinus ectasia, and transitional venous anomalies, which are similar to developmental venous anomalies, but with signs of AV shunting, particularly on ASL MRI. Some of the syndromic causes we discuss in the article are cerebrofacial metameric syndrome, where facial and intracranial venous anomalies co-occur, and Sturge-Weber syndrome, which is thought to occur due to abnormal cortical venous development. You can get deep medullary venous collaterals in that disorder as well.
Yeah, it's definitely worthwhile looking at these images in the article. So can you tell us a little bit more about bridging veins and trauma in children?
Yeah, so the bridging veins, like I mentioned, are an intriguing and kind of lesser discussed type of vein, gets special interest in children for various reasons. They play an interesting role in patients with arachnoid cysts that are complicated by hemorrhage. So relatively minor trauma can also result in bridging vein injury and hemorrhage with resulting subdural hematomas, as the bridging veins can be stretched and predisposed to rupture at the subarachnoid subdural junction in patients with arachnoid cysts. And also the venous walls may be thinner at this level where they're crossing these layers. Importantly, bridging vein injury and trauma, either accidental or abusive, is associated with subdural hemorrhage and results in a distinctive lollipop or tadpole sign of the injured vein, which you can see really well on CT, TU2 weighted, and gradient echo sequences. These can be mistaken for subarachnoid hemorrhages. They're important to know about because they can imply that subdural hemorrhage is from a traumatic etiology.
Yeah, that's great to know. What are some clinical scenarios that can be tricky? Sometimes we encounter certain things, and how can we distinguish, for example, midline scalp masses such as atretic parietal encephalocele, sinus pericardia, and dermal and epidermal cysts?
That's a good question. That's a really frequent differential that we consider when we're looking at scalp and skull masses in pediatric patients. So, atretic parietal cephaloceles has no vascular contents and can be connected to the intracranial compartment via dura-line CSF-filled tracts and can have associated intracranial vascular and cerebral anomalies, but there shouldn't be a frank vascular connection between the cephalocele and the intracranial compartment.
Okay.
Um, for sinus pericranii, on the other hand, that is actually veins that traverse the skull. And so there will be veins both inside and outside the intracranial compartment. And it's important to identify this intracranial vascular connection on imaging, which actually can be accomplished with any of the modalities, MRI, CT, or ultrasound that we discussed before. Dermoid or epidermoid cysts are avascular, usually midline masses, oftentimes with bone remodeling.
Okay, yeah, those are helpful tips. So how about vein of Galen malformation from pineal region cyst at fetal or neonatal ultrasound? How can you tell them apart?
Well, that's a good question. I think the biggest pearl is to always remember to look at any pineal region cyst on ultrasound with Doppler. And then you can perform an MRI to follow up for comprehensive evaluation, including to look for signs of steel and other important features that can affect the patient's treatment and prognosis.
Okay. So sometimes like the Sturge-Weber syndrome can look very subtle. What are some findings we can see?
That's a good question. So, like in patients, very young patients, sometimes you might not yet see the signs of Sturge-Weber syndrome. So, it's important to try to optimize your imaging in order to be able to see the findings.
Mhm.
One kind of tip is to look for areas of white matter that are hypointense on T2 weighted MRI images. It might imply some venous congestion of the white matter. And also, contrast enhanced flare can increase your sensitivity for PL angioma. So, I always add that when we're doing that kind of imaging.
Oh yeah, that's a good tip because not every place does contrast enhanced flare. So yeah. Our infant head cities, kind of alluded to before, the veins can often look hyperdense. So how can you tell if it's the thrombosed veins or they are just normal veins?
Yeah, that's a really good question that arises in our practice very, very often because these babies are often hemoconcentrated and a little bit dehydrated, but also they're the number one group in children who are predisposed to getting dural venous sinus thrombosis. That puts us in a bit of a conundrum sometimes. But these hyperattenuating distended intracranial veins, like I said, are very common. But portable head ultrasound can be used to show the patency of the dural venous sinuses. And also, there are some differences in terms of the attenuation values are a little bit lower in the engorged veins than they are in thrombosed veins, and also the ratio of the Hounsfield unit to hematocrit will be different, as we discuss in our article.
Okay, great. Yeah, it's great to help solve the problem. Is perinatal medullary venous engorgement a distinct entity from perinatal hemorrhagic venous stroke?
Yeah, it's becoming better known as an entity and more frequently described. So perinatal medullary venous engorgement is more recently described, and it differs from perinatal hemorrhagic venous stroke, which is known as grade 4 germinal matrix hemorrhage. So grade 4 germinal matrix hemorrhage happens because there's compression of the deep medullary veins due to intraventricular hemorrhage, and then you get a white matter infarct next to the ventricles. But prominent periventricular veins seen on gradient echo sequences in perinatal medullary venous engorgement may sometimes be accompanied by edema, cytotoxic injury, or petechial hemorrhage. But usually the finding that we see is just kind of some branching, foci of T2 shortening, or susceptibility following the expected course of the deep medullary veins within the periventricular white matter.
Okay, so the branching looking for the branching helps.
Yeah, exactly.
One other thing that piqued my interest is subpeel hemorrhage. What is subpeel hemorrhage? I don't think adults get those.
No, adults should never get those. So subpeel hemorrhage is an infant-specific hemorrhage, and it can occur because the pia is thought to be more loosely adherent in these young patients than it would be in an adult. And so hemorrhage can collect underneath there, and it's thought to be due to injury of the astrocyte end feet. But this type of hemorrhage can have an egg or ice cream scoop appearance on imaging, like localized in one area over a small area of cortex and extending into the sulci. And there's often associated compression of superficial medullary veins and venous infarcts, and it has a very distinctive appearance. So I'd strongly recommend anybody who's interested to look at the article and look at those examples so that they can know what it looks like.
Yeah, now we are armed with knowledge about the embryology anatomy of pediatric patients with cerebral venous anomalies. I feel more confident, and I definitely recommend taking a look at those beautiful images in the article. And I think these very practical pointers will be very helpful in planning and interpreting these studies.
I'm so glad to be able to share this article with you. Thank you so much for inviting me.
Yeah, thank you so much. We had Dr. Asha Sarma joining us, and this is our neuroradiology podcast. Please take a look at the radiographics article and hope you enjoyed this podcast, and see you next time. Thank you.